So a lot of this information is generally just how do you talk to people in general, your patients. So it kind of overlaps with just regular bedside nursing. So when you think of mental illness, what comes to y'all's mind in general?
Depression, anxiety.
Okay, what else? Anything else? Schizophrenia? Bipolar, yeah, all of those things. And so I always think about like my family members, because they're veterans, and so they have a lot of PTSD, depression, anxiety, and just different things. What about TV shows or movies you've watched? Any of those relate to mental illness? Y'all ever seen a show about it? Or substance abuse?
I think of Shutter Island, I guess.
Sugar Island?
I think of Sling Blade.
Jersey Shore.
Yeah.
Crazy.
Yeah.
Grey's Anatomy?
Anything that Shonda writes.
Yeah, definitely. I think of like Umbrella Academy and like the sitcom Mom about the substance abuse a lot. And so like, what does good mental health mean to y'all? Sport.
Like talking about it.
Yeah, talking about it, definitely.
Realize you're not the only one with those thoughts.
True.
What'd she say?
Yeah, definitely. Having like healthy relationships, being able to like manage your emotions, being self-aware, adaptable, which basically in nursing you have to be adaptable and flexible to all situations. Definitely. So mental health is like a spectrum. So you start off on the good end, you're able to adapt to the stressors of life, the cultural norms of life, and then you start to interfere with your daily living activities. Let's say you used to go to the gym, but now you're like too fatigued to go to the gym, so you're just like laying in bed watching Netflix in your spare time, right? But then it goes down to a disease of exclusion, because mental health can mimic different issues, like cardiac issues, thyroid issues, as well as brain problems. They might have a tumor, hormone imbalances. So like for older women, when their estrogen is low, like they get a little crazy or a lot of crazy, it just depends. Older people with UTIs, or if you have like a concussion. So last week I fell off the ladder putting up wallpaper. So,
Is this true?
yeah, this is true. I fell off the ladder Monday after clinical. And so I was off, so I had to take off work because I was confused and just different things that happen with having a concussion. So you have to rule out, well, hey, she fell off the ladder versus she is like depressed or having delirium or something. So the number one thing in mental illness, we always treat the medical first and rule out, is it a medical issue happening before we just like put them on an antidepressant or antipsychotic medication. So these are the key terms that goes throughout all of the disorders pretty much. So psychosis. So what does like, just overall these key terms that you see, what do they mean to you? What do you think of when you see them, see these words?
Altered mental state.
Yeah.
Definitely like the worst in the mental health symptoms
Yeah.
or diseases.
Definitely. Anybody else?
Believe that
Like ICU psychosis?
Mm-hmm.
That's really cool.
Would you say, Crystal, believe when they're seeing something that's not there?
Definitely, you'll get a lot of that. And so psychosis is really like the disconnection from reality, where they experience hallucinations and delusions. And then delusions is like their false ideas or beliefs accepted by like that person.
Can you repeat that?
Both parts.
Just the delusion.
So delusions is false ideas or beliefs accepted by that person that's real to them. So it's very common, like delusions are very common in like schizophrenic patients. They believe like people are out to get them a lot of times, or out to get someone they love. So with them, you don't really want to argue with them. You don't want to agree or entertain the delusions they're having. We as nurses wanna focus on the reality of, if they say, oh, there's a cat trying to attack me, say, I only see you and I in the room. You don't wanna be like, there's no cat there, cause then that's just gonna elevate their anxiety and their mania that they have going on. Is there any other things you think you shouldn't or should do as a nurse, dealing with someone that's delusional, or having delusions or hallucinations?
Don't turn your back.
Yeah, safety.
That's what everyone, yeah, don't turn your
Not
back.
turn your back.
Definitely. And then hallucinations is a false sensory perception without basis in reality. So they can be visual, they can be auditory, they can taste it, they can feel it.
Can you say that one more time?
So hallucinations is a false sensory perceptions with no basis in reality. So it's usually they feel visual, they could hear things, they could smell smoke, but they're in the hospital and they think they're smelling like a house burning. They could taste something, or they could feel like bugs crawling all over them. I had a patient that in the clinic, and she was like, I have bugs in my head, and it's really like dandruff that she was like picking out of her head. So that was her hallucination, that things were crawling all over. And that's common in bipolar and schizophrenia.
Hallucinations are.
Yes. So, we talked about some diseases that could happen, like far as cardiac thyroid issues. What are some natural causes you think that could cause someone to have a mental illness, be psychotic or anything? Like natural reasons?
Like, you could have like a really high fever, or do you mean like hallucinate?
Like genetics,
Oh,
like some,
okay.
like with autism. Some
Injury?
people, you said injury? Yeah, definitely injury. Substance abuse,
Postpartum psychosis.
yes. As well as like poor nutrition, sleep. Get a little delirious when you get sleepy, or get a little angry when you get hungry. Or just like your brain chemistry imbalances of like the serotonin levels and the dopamine levels. Which dopamine, serotonin could be in like depression and anxiety when they're off. So the main thing is like our role as a nurse, we must be self-aware of our personal beliefs, attitudes, values, and physical stance on things. So we are supposed to be non-biased when dealing with our patients. So what do you think is the appropriate thing to do if you encounter a patient and you're like, okay, I'm kind of like judging this patient, what do you think you should do?
Check yourself.
Yeah,
Fix your face.
yeah,
Get a mask. No, just like.
actually, that is a good thing to do, put on a mask. So,
Try to have a little bit.
yes, try to do that. Or if the bias is so high, maybe change your assignment. Talk to your charge nurse and be like, hey, this is how I'm feeling. So maybe, you know, you're on just a general med surg floor and you have a cancer patient and your grandfather just died of cancer. Might not be the best patient for you to take care of. It might start griefing you and you might be highly emotional dealing with this patient.
I was thinking if, like, you could have that one person on your shift, just to be honest with about like, hey, I'm struggling right now, like, can you? But like, it'd probably be best to just be honest with your charge nurse, like you said.
Yeah, but it's good to have support from your colleagues too.
Yeah.
Because sometimes you might not realize a bias until later on in your shift. And it might be more difficult to change your assignment then. So definitely being aware before you go into the settings. And so we wanna make sure we establish like good rapport with our patients, because the first moment of contact is how they view you basically for the rest of the shift. So we wanna establish trust. So what are some ways we can establish trust with our patients?
Follow through on what we tell them we're gonna do.
That's number one. Follow through with what you tell them you're gonna do. So don't tell them you're back in 30 minutes, because they're gonna watch the clock. And we all do it. If somebody tells us a time, we're looking at the clock for that time. What about, how do we show like respect to our patients?
Eye contact.
Yeah, eye contact. What was the other one?
Oh, like yes, ma'am, yes, sir.
Yeah, definitely. And then we wanna make sure we're being genuine with our clients. We don't wanna overtalk them. We wanna ask open-ended questions and wait for the answer, even if we're busy. And people overall can tell when you're not being genuine.
Kind of like sit, like, don't like hover over them, or talk to them.
So sit like eye contact or raise the bed if they're bed bound and you don't have a chair or something, definitely. So empathy versus sympathy, what do y'all think these terms mean?
Feel it.
Feel it. Which one? Empathy? Yeah.
Some things are feeling bad for them.
Mhm.
And empathy is like, yeah.
Yeah, so basically like you had a similar experience with empathy as your patient or friend or whomever you're talking to. It may not be the exact same, but it's very similar. And you're like, oh, I can definitely empathize with you. And sympathize, you can recognize their feelings and emotions, but you may have not had that same experience. You'll be like, oh, I'm so sorry this happened. So some of the things you don't wanna say when you're showing sympathy is at least you're still alive, or at least whatever. You don't basically wanna find the silver lining in anything. Because who wants to hear the silver lining in general? No one. But to remember that it's rare that anything you say can actually make someone feel better. And sometimes it's okay just to be silent and just be there with that patient. So transference versus countertransference. So transference is basically your patient projecting their feelings and emotions and expressions onto you from like past experiences. So basically if they had like the overbearing parent always telling them what to do, they're like, you're the nurse now, you're telling them to take their medicine. You can't tell me what to do. So they're transferring that onto you. And then countertransference is the opposite. We're projecting our beliefs, feelings, emotions, and experiences onto them.
Our past experience?
Yeah.
Or just,
Or past, they could be a current experience that you experience as well.
but we want to like check ourselves, or we want to do that?
We don't want to do that.
Okay, so we wanna check ourselves.
Yes. Cause let's say your patient, has substance abuse disorders and your parent was an addict and you ended up in foster care, and now you're treating that patient like you would treat your parent when you see them.
Okay. How do we know if we do this?
That's kind of think about when you get report about what's going on with the patient. I always think it's key to ask, how's the patient's attitude before I interact with them during the day? Cause I typically work day shift, so the night shift, did they rest well? Cause if they didn't rest well, they might be grumpy. Did they get dinner? Cause that's been a big issue at UAB, the meals. Cause they might be cranky from not having dinner, so they're starving by breakfast time. Could affect their attitudes. What did they come in with? Are they detoxing? So really finding out as much information about your patient themselves would be a good standpoint, because then you can see if you wanted to interact with that patient or should I change patients. Like, I had one of my coaches from high school as a patient. And when I heard it, I was like, is that who I think it is? And I peeked in the room and I'm like, are you sure you want me to be your nurse for today? And he assured me that he wanted me to be his nurse for today. But just knowing your boundaries, because I'm like, I felt so heartbroken. But then I'm like, okay, I gotta step into nurse mode and give him the best care that I would give, even if I didn't know him. And not to be so emotionally involved with that. So, therapeutic environment, what do y'all think the priority is? What'd you say? Safety. Yeah, number one is always safety for you and for your patient. So how could you keep a safe environment for a patient that has like suicidal thoughts?
Taking out sharp objects off the room, keeping it close to the nursing station, having a sitter.
Yeah, all of those, sitter, remove sharp objects, keep them close to the nursing station, rounding. So if you've done all those measures, let's say your patient is schizophrenic and they're mad, and so they're all over the place. You've tried like redirection, comfort measures. What do you think could be a next step for that patient?
Medication?
Yeah, you could give them some medications, like ask the doctor to prescribe medications. If they're combative, you might wanna try like restraints and start off with like, we always wanna do least restrictive to most restrictive. So like the hand mends. Then we wanna go to like the soft wrist restraints. And then you might have to go to those 2-point restraints. And then if they're actually in the psych ward, they actually have a lock and key restraint that they can put on them. How would you really want to approach your client? Like we said some of this earlier in the PowerPoint. How would you really want to approach this person that's in active psychosis or delusions, hallucinations?
Calm.
Yeah, calm. We mentioned about like being closest to the door, making sure they see you when you're coming up to them. Do we really want to touch this patient? Do we want to argue with the patient? Communication. So how do we communicate therapeutically with our patient? Is it only verbal touch or is it both?
I mean, I think it depends on the patient, I think. Like you were talking about, like a combative patient. It would depend on the patient, I think.
Definitely, it definitely depends on the patient. And it allows us to kind of see what's going on with our patient, how they'll perceive us when we walk in and we introduce ourselves. So it's a combination of all the above. We wanna have like the right verbal communication with them. We wanna sit, present. If you have your computer, your WOW, you wanna face it toward the patient where you can see both of them. Because you can be like charting or doing whatever on your computer, but you also wanna be able to engage in conversation quickly when things get like more serious. Maybe they're telling you about a pain or something that they're having. So you wanna show that as well to them. You wanna be very concrete when you're talking to your patient. You don't wanna be like, use it figurative of speech. Or slang terms like FOMO or, anything up for interpretation. You wanna ensure like the touch is welcomed. So if someone's crying, you can maybe ask like, is it okay if I hold your hand during this moment? Just try to assess it. And it's okay to ask those questions as well. A big thing you wanna be aware of like your facial expressions with like maybe wear the mask if you have like facial expressions and like body language posture we talked about. We don't wanna stand there with our hands on our hips or our arms crossed. Like, that's very close communication. If we are sitting, we wanna sit with our, like, maybe cross at the ankles or not cross your legs at all
So like nonverbal communication.
as well. We want to ensure like our vocal cues as well, so like our volume, our tone, our pitch, our intensity, our emphasis, as well as our speed and our pauses in the conversation. But our primary focus overall is to make the client in front of you feel most comfortable. So then they open up to you more, which makes your shift better, because then you know what they want. And so you can provide that. So we always want to like assess our patient, create that safe environment, use therapeutic communication, and structure the environment for the situation which we discussed. But an important thing is to know like what medications are your patients taking? Why do you think that's important? Especially in relation to mental health.
Yeah. Something's going on with their brain, like their head, side effects, like next up. Right, you said that? You said side effects?
Side effects. So let's say someone's on a beta blocker. What things do you give like beta blockers for? What can you give them for? Hypertension? Yes. Anything else? Anxiety. So they could be on it for a variety of reasons. What about benzos? What do most people take benzos for? Yeah, anxiety, but also seizure disorders. What about gabapentin Lyrica? Yes, epilepsy as well as anxiety as well. And like lithium, you can take it for cluster headaches, but it's also like a mood stabilizer.
Lithium is for bipolar?
Yes, definitely. So it's very important to know what medications your clients are taking as well as what they are actually taking it for. Because then that gives you a better general idea of like, okay, this patient on their home medication is not a beta blocker, says for anxiety, but they're not on it in the hospital. Maybe that's something you should ask the physician to order for that client. If their anxiety level is low.
Usually in the hospital, you're more anxious,
You are, but I've had some clients, I know people that's in my clinical group, we had that one patient that has all these depression and anxiety medicine, but they're a very anxious person.
Of that one,
Yeah.
yeah. Hey, it ain't working.
Basically, so we
These
need
meds ain't working.
patient doctor. Okay. So I forgot to add the other side before this, but I think it might be in y'all's PowerPoint. But there's different nursing, like mental health assessments you can do, like the mental status exam you can do as a nurse, the CAGE for alcohol abuse, the GAD-7 for anxiety. It's not on here. I think it might be a slide on your PowerPoint. Do you see it? Okay. Well, those are just some examples of nursing assessments you can, mental health assessments you can do.
What was the third one?
So I said GAD-7 for anxiety, mental status exam, and then the CAGE for alcohol. I'll have to upload that side for y'all.
And then alcohol.
So, let's skip on to it. So these are different treatments that we can do. We can do ECT therapy, medical. Antidepressants for depression, psychotalk therapy, just an array of different things that we can do for our patients. And so psychosis care. You definitely want to make sure that you have a positive, non-judgmental demeanor when approaching these patients. You wanna use respectful communication, active listening, supportive presence, because we wanna build trust, reduce stigma, have open communication, which is very important, and promote emotional safety for our patients.
So do not touch. So we don't want to touch them?
No, if they're psychotic,
Oh, psychosis, sorry.
yeah,
Okay.
they might think you're a dragon trying to attack them and come after you and jump off the bed.
Okay.
So would you not want to reorient them to know that they're in the hospital or anything like that, or?
It depends on the level of
Okay.
psychosis, but
Okay.
sometimes you can redirect them.
Right.
Like, hey, you're in the hospital, you're here, or ask them, well, do you know where you are?
Okay.
What are you seeing?
So UAB has that, like, that assessment that we did, like, when you first come in, but this is something different. You wouldn't do that for this kind of patient, right? It's like a altered mental assessment. Yeah, status.
That's general for everyone.
Okay.
That they do, this is just talking about psychosis, like active psychosis.
Okay,
here.
okay. This
Oh,
is
which
something different.
Mhm. So validating their feelings, we wanna use like reflective listening. It sounds like you're feeling overwhelmed right now. It's good. You wanna normalize their feelings that they're having. Like it's completely understandable to feel sad after what you've been through is appropriate. Yeah, we went over. And you wanna ask open-ended questions and encourage their expression of what's going on. That they're not just holding in anger if they're saying that they feel angry. Maybe physical grounding techniques like the 5, 4, 3, 2, 1. So name 5 things you see, 4 things you feel, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. That's something you can do as a bedside nurse and don't have to have an order for. Deep breathing. Or describe the environment around you, or maybe count sheep, like imagine sheep and count them. And you want to like verbally support them as a nurse, like let's take a moment to take a deep breath together.
What is the, be aware of command psychosis?
Oh, we hadn't got to that.
Oh, sorry.
Yes,
Sorry about that.
no problem. How should we like properly distract our patients?
Tell me something, can you say that, or like, what did you eat for breakfast?
Yeah. You can use conversation.
Can you
Talk about interest, did you say?
So you can use grounding too, as a way to distract them, right? Or like.
Yeah.
Bring them back to reality and just be like, I don't know.
Can give them a stress ball.
Yeah.
Or chewing gums for like taste. Maybe like a puzzle if they're,
Or like what show you watching right now, tell me about the show.
yeah, count the squares on the floor. Like, let's take a lap around the unit together. Some people are, maybe coloring, as long as they're not like suicidal, try to swallow the crayons.
You don't have minutes on.
It's important to figure out like our patient's triggers, like knowing some background history on them. And sometimes you can ask the patient and they'll ramble on about some of it's actual reality and a lot of it isn't, but you can kind of figure out. And offer choices. You don't wanna take away their choices. So being aware of like command psychosis, you wanna know if they're like, hey, I'm hearing somebody tell me to kill you. You want to know that. You wanna know what the voices are saying to them, like ask, okay, what are you hearing? So for them to tell you what they're hearing. Where do you see this person? And it's okay to ask them like, what is it telling me to do? It could be like, as well as suicidal, it's telling me I'm worthless, I don't belong here, I need to just jump off a bridge. Don't know. So that's very, very important to know. And So these are exemplars for this class that we'll mainly focus on. Okay, so. So our first one is depression. So what is depression? Yeah, all the above. Feeling sad for 2 weeks or greater, inability to do your ADLs, activities of daily living, brushing your teeth, bathing, eating, plus a cluster of 5 to 6 symptoms like inability to feel pleasure, their changes in their weight, your appetite, sleep, energy levels being very low. They can't concentrate or make good decisions, having low self-esteem. Let's say they were a runner, now they don't even wanna go for a walk. It could be small changes like that that shows that somebody's depressed as well as it can lead into suicidal ideations or attempt for suicide, which is like key in all mental health issues. We are always assessing for suicidal ideations. And in the same way that we talked about before about communicating with our patients, you wanna continue to do that with a depressed patient as well. So our biggest thing, like I said, in depression is suicide, so we want to make sure we do a detailed assessment of it, asking them, are they having thoughts just straight, have you ever thought about killing yourself in the past 2 weeks? And they have to say yes or no. Do you have a plan to kill yourself? Asking those concrete questions, they'll say yes or no to them, and I've had patients to say yes, and I was very shocked because I was like, wow, okay. Now we have to take the necessary precautions for that. And we want to be aware of like somebody that was depressed, and let's say 2 days later we come back and they're super happy, loving life, and they're calling everybody and saying, you know, whatever their last discussion they wanna have with them. That actually happened to me. One of my ex-boyfriends called me, and we were supposed to all hang out for our birthdays. And I was one of his last calls, and he committed suicide, and he had attempted before with Tylenol. Yeah, but his roommate was an EMT, and so then he started working at a pawn shop. Bought a gun at the pawn shop and committed suicide that way. So you gotta be aware of those changes in a person.
Wait, y'all weren't like talking?
No, we weren't.
And he just randomly called you and then said, rekindle something?
Us to all hang out for our birthday. And I was like, okay, cool. And then he called, I was on his last calls, which I didn't answer the phone call, but yeah, literally 2 days later, my friend called me and said he committed suicide. And that's how he ended up with everything. So you have to be aware of those. Yes. In which we all knew that he had already attempted, that's one of the reasons why we weren't together, but still. You have to be aware, and then also those people who are suicidal will try to take people around them with them. So you have to be aware, because they might be like, I'm gonna kill you and kill me. So it is a huge thing. So we went over some of the priority assessments. We want to someone that's actively suicidal, we wanna have a one-to-one sitter. We want to round on them every 15 minutes. Well, it depends on what hospital you work at. UAB is like 30 minutes for the nurse, and then 15 minutes for the sitter. You have to document where the patient is in the room. Maybe your patient is ordering medication, so you might wanna be like, open your mouth, cough, give them something to eat afterwards, and make sure they're not trying to save up those pills. You wanna keep open lines of communication with your patient.
So would you say that building trust with that patient is vital, that they trust you?
It is. It's very vital that your patient trust you. That's why we're building a rapport as soon as we walk in the room with every patient. Because you may have a patient that's there for, let's say, CHF. And they trust you so much, like, hey, I am tired of going through these cycles. I just wanna leave this earth. And, or say, I just wanna leave. So you need to inquire, well, where do you wanna go when you leave? Cause they might be like, oh, I wanna go home. Oh, you're home in Hoover? See where, and just trail that down, because they might actually indirectly be talking about suicide. But you think they're just about to just go to the house. So we need to definitely escalate that. And then some people, they attempt suicide one time and they may never attempt it again. It just all depends. Being aware, like we said, of the nonverbal cues of suicide. They may feel relief to finally talk to someone that can sympathize and empathize with them, decrease their isolation. So having the sitter, the other sitter's watching them, but maybe the sitter can like, just have general conversation with them. Be more of like a friend support during that time. And then there's some crisis hotlines, centers, support groups for this. I believe here we also have those support groups as well in Gestate. And then this is just some extra resources for y'all. And sleeping. Sleeping is a big deal as well. As say your patient all of a sudden starts sleeping a lot. So you need to see, are they hoarding medications? You know, are they walking around the unit and getting drugs from another patient? Because if they're just on a regular medical floor and not in the psych ward, they could be talking to other patients and getting their opioids or whatever it is. That has definitely happened before to me. A patient was walking around the unit and stealing people's food, and yeah, they would go down and we found out they were doing drugs together. Now they didn't have active mental illness going on, but that does happen. So some antidepressants, we can put them on like some TCAs, like amitriptyline is a big one. And so we really wanna watch out for anticholinergic effects. So like, it'll drive the person, increase their risk for like seizures, decrease urine output, constipation, so we want to focus on those to make sure they're hydrated. Also, on amitriptyline, if they miss some doses, they might look like they're wanting to withdrawals from amitriptyline. And your patient is a fall risk because of the orthostatic hypotension. So other antidepressants that we can give is like SSRIs and SNRIs. And so like fluoxetine and duloxetine. And they have like different side effects. So our serious side effects for them is like suicidal risk, which is major if your patient's on any of these, because we keep talking about that suicide. You know, sexual dysfunction, and then it's slow onset and slow taper off. So your client might be complaining of, hey, it's taking forever for me to feel better. Or once they start feeling better, they might want to just discontinue the medication. I feel fine, and they just abruptly discontinue the medication. So you want to do like patient education is key here. And it's gonna take.
What is like the asterisk by some of them? Like, is that just?
It's just like common ones that you normally see in the hospital setting that they generally give. I mean, they give Lexapro, which is the first one. Celexa, which is the next one. They give sertraline, but.
Was SI risk suicidal ideation risk?
Yes, SI is suicidal ideation risk. So you want to, our key here is to watch out for serotonin syndrome, because this is rare, but it's potentially life-threatening situation. So the patient may start sweating and you're like, okay, it's cold in here. You need to start getting like get vital signs, check the fever. It's typically like 100 and something fever, like maybe 101, 105 fever. So you wanna make sure like you page the doctor, you wanna stop the medication. Let's say this patient's been sweating all night long and the night shift nurse didn't catch it and now you're there and you're like, what's going on? What new medications was added yesterday? And so you might wanna hold that medication that you see this antidepressant and page the doctor and be like, hey, this is what's happening to this patient. The medication was started 2 days ago or a day ago. Cause it can happen in a few hours of starting this medication, which basically is too much serotonin in your body. They might have their regular heartbeat, or they might pass out. So if they're like tachycardic, you might have to put them on pressors. You really don't wanna give Tylenol or make that recommendation to your physician, cause it's not gonna help in this situation. Because basically, the fever and high temperatures from the muscle activity and the changes. We wanna make sure they order some IV fluids for this patient, cause definitely like when you work out, you get dehydrated, you gotta hydrate. We're basically just providing supportive care for these patients that go into serotonin syndrome. So MAOIs, this is one that we don't see as often just because its therapeutic window is so small, so it's hard to keep track of it because like 0.1 above could send them into like massive hypertension, which is basically serotonin syndrome as well. So Inflex loves to test on MAOIs just because we don't give them often, but they're so high risk. So we don't wanna give them with any, mainly they try to go more towards like the food, like fermented foods, beer, wine is more like the questions they like to ask. You don't wanna give it with other antidepressants, which is the major thing. So if they're on an MAOI, they shouldn't typically be on any other antidepressant. And if they are, you might wanna definitely page the doctor and see, hey, did you notice this? Over-the-counter meds like NSAIDs, we don't wanna get it with, and antacids and calcium. So if you're having like just some acid reflux or something, you might want to take that 2 hours before even taking this medication in the morning. And it does increase risk of suicide. So even though we're giving these medications to help with depression, and depression already increases your risk of suicide, these medications also amplifies that risk for suicide because the patient is feeling better, so they feel like their problem is gone, or they have enough energy to continue with that suicidal plan they already have. So that's why it's an increased risk for suicide. Oh, and some fermented foods would be like yogurt, sauerkraut, pickles, kefir, sourdough bread, some of those that you might see on your exam too.
Wanna avoid those?
Yeah.
What was that for pickles?
Pickles, sauerkraut, sourdough bread. There's a whole list, so you would just provide patient education if they're started on this medication. We're gonna say like, hey, this is what you need to watch out for, give them a pamphlet, list it out, cause then they'll know like, hey. And then ECT therapy. So basically, tiny electrodes, current is applied to the patient's brain through electrodes, and it's placed on each side of the skull. And it basically triggers a 30-second seizure to and the patient is under general anesthesia. So you can use this in severe major depression, but you can also use this in like bipolar disorder as well.
Is it depression and bipolar?
Yes.
Is it general anesthesia?
Yes, they'll have general anesthesia for this.
I've seen this like basically bring back a catatonic patient one time, it's crazy.
So, this is the Queen of Hearts from Alice in Wonderland. So she has all those rapid mood swings, impulsive decisions, unpredictable behavior. So if our exemplars, which one do you think she represents? Bipolar, definitely. So there's different bipolar 1 and bipolar 2. We're mainly focusing on bipolar 1. So this is like severe extreme highs of mania basically, and extreme lows of depression. And they just go in and out of these constantly. So that in their depressive state, just like regular depression, sad, fatigue, hopelessness. This usually is after mania happens. And in mania, like with their high energy, they have like increased things that happens and decreased things that happen. So such as increased agitation, they're more euphoric, rapid thoughts, patterns, they're more promiscuous. And then on the decreased end of mania, shortened attention spans, shortened awareness to the illness that's happening. They're basically too busy to eat or sleep. They're on go. They're like, I got this brilliant idea. They clear out their savings, quit their job, like all of these rapid changes. Like, one of my family members, when they go into the manic phase, they like wanna get rid of everything, just throw it out, and they go to the store and buy all new stuff. So we're like, hey, have you been taking your medication? Kinda do. And so mania definitely can become a medical emergency for our clients. Why do y'all think?
Harming themselves or others?
Yeah, harm themselves or others, like sleep deprivation, dehydration, because they're not eating, drinking. And then obviously with depression, that can lead to the suicide. So we have to definitely watch for those. And so here's some of the symptoms that they'll have. It's a lot of impulsive behavior that you might see more so at the bedside, or racing thoughts. You see somebody just switching, and it's not really ADHD, like they're just, literally their sentences just continue, and it's not, oh, squirrel, like type deal. You can definitely pick up on this. So, as nurses, what do you think our focus should be on with these clients?
Trying to make sure they take their meds every day, like getting them level.
Making sure I
Yeah,
quit
medication
nutrition.
adherence,
Yeah.
room safety, like you're saying, having someone in the room with them, like, they shouldn't have two people in the room, like, two patients in that room. It should be just that patient.
Definitely, you wanna have their own room. I think you said like, make sure they're hydrated, nutrition. We want to calm environment, we said earlier, and we want to set realistic goals for behavior. And we wanna watch for signs of frustration. So we wanna do like short tasks, like, oh, let's brush our teeth for 60 seconds, like. We wanna encourage like day naps, like, oh, let's turn off the lights for 30 minutes. And then treatment, we wanna make sure they're medically stable. We might have to do some transcranial magnetic stimulation for depression, ECT, different kind of psychotherapy is really good. And so structure environment for them to talk and identify like these patterns themselves and their behaviors. So we wanna see how their core feelings and actions are really interconnected. And we wanna focus on like ways that they can cope and problem solve. And then we want to obviously medicate them. So we have Alice in Wonderland. She is seeing shape-shifting landscapes and talking animals. She's very disconnected from reality, so. Which one is it? Yeah, definitely, she's schizophrenic. So she has like positive symptoms, negative symptoms, and cognitive symptoms. And so really psychosis and schizophrenia about look the same. To be honest, they're very overlapping with having the hallucinations and delusions. But in psychosis, it's more disorganized thoughts and behavior, whereas in schizophrenia, they're just like randomly all over the place. They have like less an emotion, catatonic-like behavior. And to be diagnosed with schizophrenia, one of these must experience at least 2 of these symptoms for six months. Or one for the first 3 months. Whereas psychosis is normally due to like sleep deprivation, substance abuse, other conditions.
So 1 to 2 of the symptoms for 6 months, 2 of the
Yes,
symptoms for
2.
about 6 months?
Yeah. And 1 for 3 months. Which we're not there to diagnose, but if you see this and they're undiagnosed, then maybe you could help diagnose schizophrenia, like with the doctor, like letting them know, or the nurse practitioner, that you've observed this in your patient, because you might work with peds as well. So the treatment is assessing them for those symptoms, positive and negative symptoms. Are they delusional? Are they having hallucinations? Are they disorganized speech or behavior? You wanna talk to their family if you can, like, how long has this been going on? You wanna observe for them like pacing, rocking back and forth. Or like abnormal eye movements, like looking all around the place, like while you're talking to them. And we wanna get them into like group therapy, Medicaid, behavioral therapy, and create a community for them as well. So some mood stabilizers, we use them for bipolar and schizophrenia. And the common one they like to talk about is lithium. And so this has a small range like we mentioned before. Over 1.5 is toxic. So we want to increase their fluids and salt because we don't want them to get dehydrated or hyponatremic. I had a schizophrenia patient and he was drinking the shower water because his sodium was off, he was constantly thirsty. It was a mess, called the police several times on him. So we had to medically stabilize him for him then to go get his proper treatment in the psych ward. We want to avoid diuretics because that's going to dehydrate them. Caffeine is going to dehydrate them. We don't want to over hydrate them as well. So we got to find that proper balance. So if they're like working out or something or outside in the hot Alabama sun, we wanna make sure they stay hydrated, so they're not dehydrated, just small things like that. We wanna hold NSAIDs because they interact negatively together. And then like if the patient can't tolerate lithium, we might put them on like valproic acid for like the rapid cycling for mania or Tegretol for mania.
You said that one more time.
We might wanna put them on valproic acid or Tegretol for mania.
What was the second one?
Tegretol, Tegretol. So then antipsychotics, we got typical and atypical. So these treat bipolar and schizophrenia. And so we really wanna watch out for neuroleptic malignant syndrome because it's very life-threatening. And it is rare to happen, but it can happen in both the typical and atypical antipsychotics. So it's basically high fever, muscle rigidity, blood pressure changes, difficulty swallowing. So they might have to be intubated, we might have to give dantrolene for a muscle relaxant. We wanna cool them off because Tylenol's not gonna work for this, like with ice packs or cooling blankets. And we wanna watch for elevated white blood cell count and creatine kinase. So basically, we wanna discontinue the medication